If you don't know these 4 signs in the next 10 seconds, you could watch someone you love lose the ability to speak or walk right in front of you. The FAST test is a simple, rapid screening tool designed to help ordinary people recognize the most common signs of a stroke within seconds, because stroke is a medical emergency where time directly equals brain survival. The idea behind FAST is that a stroke often disrupts blood flow to specific areas of the brain that control facial muscles, arm movement, and speech. So problems in these functions can appear suddenly and be noticed without any equipment or medical training. The first part, face, focuses on facial symmetry because the brain controls the 2 sides of the face through neural pathways that can be disrupted by a clot or bleed, causing one side of the face to droop or feel numb. When you ask a person to smile, you might see a crooked smile, a sagging mouth corner, or one eye that doesn't close properly, all of which suggests that the facial muscles are not receiving normal signals. The second part, arms, checks for weakness or paralysis in the limbs, since many strokes affect motor areas of the brain. When the person is asked to raise both arms straight out in front of them, one arm may drift downward, shake, or fail to rise at all, even if the person is trying, and sometimes the person may also report heaviness or numbness, reflecting impaired motor control or sensation. The third part, speech, evaluates language and articulation, which are commonly affected when strokes involve language centers or the muscles used for speaking. You can ask the person to repeat a simple, familiar sentence, and warning signs include slurred words, incorrect words, jumbled order, difficulty finding words, or speech that is hard to understand, and occasionally the person may seem confused or unable to comprehend what you're saying, which also signals a possible brain event. The final part, time, emphasizes that if any one of these signs is present, even briefly, emergency services must be contacted immediately because modern stroke treatments such as clot-dissolving medications and mechanical clot retrieval are highly time-dependent, working best when given as soon as possible after symptom onset, and every minute of delay allows more brain tissue to be deprived of oxygen and nutrients. FAST is effective because it turns complex neurology into a memorable checklist that can be applied anywhere, at home, at work, in public, and it encourages decisive action instead of hesitation, since people often misinterpret stroke symptoms as fatigue, low blood sugar, or stress, leading to dangerous delays. By using FAST, a bystander essentially becomes the first link in the stroke survival chain, recognizing abnormal signs, noting the exact time symptoms started, and triggering the emergency response system so the patient can reach a stroke-ready hospital quickly, which dramatically improves the chances of recovery and reduces the likelihood of long-term disability. The 3 to 4 hour golden window in stroke care refers to the critical period after stroke symptoms first begin, during which certain medical treatments can significantly reduce or even reverse brain injury. Because most strokes are caused by a blood clot blocking an artery in the brain, cutting off oxygen and glucose that brain cells need to survive, and when this supply stops, a cascade of cellular damage begins almost immediately, disrupting energy production, causing toxic chemical release, and leading to cell death in the core affected area, while surrounding tissue, known as the penumbra, remains at risk but potentially salvageable if blood flow is restored quickly. Clot-dissolving medication, commonly called thrombolytic therapy, works by breaking up the obstructing clot and reopening the artery, but its benefits are highly time-dependent because the longer a vessel stays blocked, the more brain tissue progresses from reversible dysfunction to irreversible infarction. And studies have consistently shown that patients treated earlier within this window have better functional outcomes, lower disability, and higher chances of returning to independent living compared to those treated later or not at all. The reason the window is limited is partly safety, since these medications also carry a risk of bleeding, and as damaged brain tissue becomes more fragile over time, the risk of dangerous hemorrhage increases, so doctors must balance potential benefit against harm, which is why strict time criteria and imaging assessments are used before giving treatment. Mechanical thrombectomy, a procedure where specialists physically remove a clot using catheters threaded through blood vessels, can sometimes be performed beyond the basic 3 to 4 hour window in selected patients. But even then, earlier treatment still correlates with better outcomes, and eligibility depends on imaging that shows viable brain tissue, meaning time still plays a central role. The concept of the golden window underscores that stroke is not a gradual illness but an acute vascular event where millions of neurons can be lost each minute. And unlike many other cells in the body, mature neurons have very limited capacity to regenerate, so lost neural networks often translate into permanent deficits in movement, language, memory, or vision. This is why delays such as waiting for symptoms to pass, contacting family first, or driving long distances instead of calling emergency services can quietly consume the treatment window, and why medical systems emphasize rapid recognition, pre-hospital notification, and direct transport to stroke-capable centers. Recording the exact time when the person was last known to be normal is medically crucial because it anchors all treatment decisions. And if the start time is unknown, many patients become ineligible for certain therapies even if they arrive at the hospital relatively quickly. Public education about this window aims to shift behavior from hesitation to urgency, treating stroke signs with the same seriousness as cardiac arrest, because fast action can preserve brain function, reduce long-term disability, shorten rehabilitation, and dramatically change quality of life outcomes for survivors and their families. During a stroke, especially an ischemic stroke where a blood clot blocks an artery in the brain, the statement that every minute matters is not a metaphor but a reflection of real biological damage occurring in real time, because neurons depend on a constant supply of oxygen and glucose delivered by blood, and when that supply is interrupted, the affected brain tissue immediately shifts from normal metabolism to an energy crisis, failing to maintain ion balances across cell membranes, which leads to depolarization, calcium influx, release of excitatory neurotransmitters like glutamate, and activation of destructive enzymes that damage cell structures. Researchers have estimated that in a large untreated vessel blockage, the brain can lose around 1.9 to 2 million neurons per minute, along with billions of synapses and significant lengths of myelinated nerve fibers, meaning the brain effectively ages weeks to months in biological terms for every hour a major stroke goes untreated. This rapid loss matters because different brain regions control different functions, such as movement, sensation, speech, vision, and cognition, so the location and duration of reduced blood flow shape the pattern and severity of disability. And as time passes, the area of irreversible damage expands outward from the core to surrounding tissue that might initially be dysfunctional but still viable. Early on, some neurons in the penumbra are electrically silent yet structurally intact, making them potentially recoverable if circulation is restored quickly, but prolonged deprivation converts this salvageable zone into dead tissue through processes like oxidative stress, inflammation, and breakdown of the blood-brain barrier. The phrase "time is brain" is used in stroke medicine to emphasize that speed is a form of treatment in itself, since faster recognition, faster emergency response, and faster hospital evaluation directly translate into more brain tissue saved, better neurological outcomes, and lower long-term disability. Waiting to see if symptoms improve can be dangerous because some strokes fluctuate or partially improve while the underlying blockage remains, and each minute of delay quietly increases the volume of infarcted tissue. This is also why stroke systems of care focus on rapid triage, pre-hospital stroke scales, and direct routing to specialized centers, and why clinicians push to minimize door-to-needle and door-to-groin times for reperfusion therapies. From a functional standpoint, the loss of millions of neurons is not just a number, but a reduction in complex networks that encode skills, memories, and coordinated actions. And while the brain has some plasticity and can reorganize to a degree, large losses often leave lasting deficits that require prolonged rehabilitation and may never fully resolve. The urgency surrounding stroke is therefore grounded in cellular biology, vascular physiology, and outcome data showing a strong relationship between treatment delay and poorer recovery, making immediate action one of the few factors that bystanders and patients can directly influence in a condition where so much else feels out of their control. A transient ischemic attack, often called a mini-stroke, is a brief episode of neurological dysfunction caused by a temporary reduction in blood flow to part of the brain, spinal cord, or retina, and although the symptoms resolve on their own, the underlying mechanism is similar to an ischemic stroke, usually involving a small clot, platelet aggregate, or severe narrowing in a blood vessel that momentarily blocks circulation and then dissolves or moves on before causing permanent infarction. During a TIA, a person can experience the same kinds of symptoms seen in a full stroke, such as sudden weakness on one side of the body, facial drooping, slurred or lost speech, vision problems, numbness, or difficulty with balance and coordination, but these deficits typically last minutes to less than an hour, and by definition resolve within 24 hours, often much sooner, which leads many people to mistakenly believe the event was harmless or unrelated to the brain. In reality, a TIA is one of the strongest warning signs that a major stroke may be imminent, because it signals that the vascular system supplying the brain is unstable, whether due to atherosclerotic plaque, atrial fibrillation generating emboli, small vessel disease, or other circulatory problems that have not been corrected. The risk after a TIA is front-loaded, meaning the danger is highest in the hours and days that follow, with a significant proportion of subsequent strokes occurring within 48 hours, and overall estimates commonly show that up to about 40% of people who ignore a TIA will suffer a full stroke within the next 3 months, many of which result in permanent disability. Biologically, even if symptoms disappear, the episode indicates that brain tissue was stressed by inadequate perfusion, and repeated or longer interruptions can push vulnerable regions past the threshold from reversible dysfunction to irreversible cell death. Clinically, a TIA should trigger the same urgency as a completed stroke, prompting immediate medical evaluation, brain imaging, and vascular studies to identify the source of the problem, because interventions such as antiplatelet therapy, anticoagulation for certain heart rhythms, blood pressure control, cholesterol management, or procedures to treat severe carotid artery narrowing can dramatically reduce future risk. The danger partly lies in human psychology, since symptom resolution creates a false sense of safety, encouraging delay, denial, or attribution to fatigue, dehydration, or stress, which wastes the critical period when preventive strategies are most effective. From a public health perspective, TIAs represent a window of opportunity where the brain has essentially sent an alarm signal without yet paying the full price of permanent injury, and recognizing that alarm allows clinicians to act before a catastrophic event occurs, transforming what looks like a minor, passing episode into a chance for aggressive prevention and risk reduction through targeted medical care and lifestyle modification. The idea that about 80% of strokes are preventable comes from large epidemiological studies showing that most stroke risk is driven by modifiable factors related to vascular health, meaning the condition of blood vessels and the characteristics of the blood flowing through them, and when these factors are controlled, the probability of clot formation or vessel rupture in the brain drops substantially. High blood pressure is the single most important risk factor because chronically elevated pressure damages the inner lining of arteries, promotes atherosclerosis, and makes vessels more prone to both blockage and rupture. And over time, it causes small vessel disease deep in the brain that can lead to lacunar strokes and cognitive decline. The danger is that hypertension is often silent, producing no symptoms while damage accumulates, which is why regular measurement and adherence to prescribed medication are central to prevention. Diabetes contributes by exposing blood vessels to high glucose levels that trigger inflammation, oxidative stress, and structural changes in vessel walls, accelerating atherosclerosis and impairing the body's ability to regulate clotting. So good glycemic control, typically monitored through metrics like HbA1c, reduces microvascular and macrovascular complications that include stroke. Abnormal cholesterol, particularly elevated LDL, facilitates the formation of fatty plaques inside arteries supplying the brain or leading to it, such as the carotid arteries, and these plaques can gradually narrow vessels or suddenly rupture, forming clots that travel to cerebral arteries. Lipid-lowering strategies through diet, exercise, and medications like statins stabilize plaques and reduce event rates. Smoking affects stroke risk through multiple mechanisms, including damaging the vascular endothelium, increasing blood coagulability, reducing oxygen delivery, and promoting atherosclerosis, and cessation leads to meaningful risk reduction within a few years as vascular function partially recovers. Physical inactivity, obesity, and poor diet cluster with these conditions, often driving hypertension, diabetes, and dyslipidemia, while regular aerobic activity improves blood pressure, insulin sensitivity, lipid profiles, and endothelial function. Certain heart conditions, especially atrial fibrillation, raise stroke risk by allowing blood to pool and clot in the heart before traveling to the brain, and appropriate anticoagulation in selected patients markedly lowers this risk. Alcohol overuse, chronic stress, and sleep disorders like sleep apnea also influence vascular risk through effects on blood pressure, metabolism, and heart rhythm. Prevention, therefore, operates on two levels: population habits such as healthier eating patterns, rich in fruits, vegetables, whole grains, and unsaturated fats, along with routine physical movement and smoking avoidance, and individualized medical management targeting measurable risk factors with medications and monitoring. What makes prevention powerful is that vascular biology is dynamic, so improving these variables can stabilize plaques, normalize pressures, and reduce thrombogenic tendencies, shifting the probability curve away from acute cerebrovascular events even in older adults or those with prior risk accumulation, and the cumulative effect of several modest improvements is often larger than one dramatic change in a single area.